All right. Thank you for joining us this morning. Could you please tell us your name and title and what procedures or research you work on?
Sure. So my name is Michelle Paff. I'm an assistant clinical professor for the Department of Neurosurgery. And my specialty is deep brain stimulation and functional and stereotactic neurosurgery.
So what's important to know about those procedures? What do they treat, and what's important to know about the disease conditions they treat?
Right now, the three most common types of diseases that we treat with deep brain stimulation are essential tremor, treat with DBS, but those are the three most common, and those are the FDA approved indications so far. There's also DBS is also FDA approved to treat epilepsy, which I have done a case there. That type of case, those are not very popular at this institution, but so the most common disease conditions that we treat are Parkinson's, essential tremor, and dystonia. Parkinson's disease is obviously the second most common neurodegenerative disorder in the world, and basically these patients take dopamine replacement therapy because the reason that they get the disease is because of degeneration of dopaminergic neurons in the basal ganglia. And what happens over time is after they've been taking this medication for many years is they start to get side effects from the medication. And when that happens, usually that's the time that we start to consider them for deep brain stimulation. With essential tremors, essential tremor is also a very common, I guess, neurological condition. There's no dementia involved, but it's just basically action-related tremors that happen. It tends to be genetic and progressive, but the cause of it is not very well understood, and medications don't work very well for essential tremor. So surgical treatment is kind of the, once the patients get to that point where their symptoms get bad enough that they want to undergo surgical treatment, that's really the mainstay of therapy for them. And so deep brain stimulation can essentially eliminate their tremor in some cases, and it can be adjusted over time. And finally, dystonia. DBS is used for generalized dystonia, and this is a more kind of rare condition that I don't see quite as much as essential tremor and Parkinson's disease, but this DBS procedure targets the globus pallidus, similarly to the globus pallidus target in Parkinson's disease, and basically it takes a little bit more time in programming to alleviate their dystonia, but it's also very effective. And so those are the three most common disorders we treat with deep brain stimulation.
It's incredible that this procedure exists for all these varied indications. Historically, has treatment been limited to pharmacotherapy for each of these conditions?
One thing I do know is for Parkinson's disease, at least, back in the 50s and 60s, the only way to treat tremor was with a procedure called a thalamotomy. And a thalamotomy is actually a lesioning procedure where you lesion a part of the nucleus in the brain. And before the introduction of levodopa medications, that was the only way to treat tremor. And the problem is that when you did bilateral thalamotomies to treat tremor on both sides of the body, patients had a lot of side effects, especially speech side effects, where they couldn't form their words, couldn't talk properly, couldn't express themselves. And so that was kind of a limiting factor. And basically the way that deep brain stimulation was invented is because doctors and scientists wanted to have a way to kind of produce a lesion effect on the second side after a thalamotomy. And so the first clinical trials of this therapy were on patients who had a prior thalamotomy, and then they got an electrode on the other side, because basically the electrode is creating a lesional effect, but in a reversible manner. That's the whole idea. And so once that was discovered, deep brain stimulation targeting the globus pallidus and also the STN, or the subthalamic nucleus, those quickly followed.
That's a super interesting evolution to go from thalamotomy to this procedure. On the other side of things, where do you see room for improvement or current improvement being done on deep brain stimulation?
Well, I think for me at least, and I know that everybody's a little bit different, but for me, I think that there's a lot of room for looking at other disorders, how we can target different parts of the brain to treat other types of disorders, like psychiatric disorders, pain, and all kinds of things. We just don't really understand much about the circuitry in the brain. It's very complicated, and we don't very much understand how deep brain stimulation works in all cases. And so I think that what I think is really interesting is figuring out the circuit dysfunction in some of these other neuropsychiatric diseases, and potentially using electrical stimulation to treat neuropsychiatric disorders. So I think that's really interesting.
That's incredible. And the last question I have for you is, when you perform one of these procedures, are there any technical challenges with the procedure that, from an engineering or design standpoint, you see there could be a room for improvement in terms of maybe something being a little too difficult or something that should be a little simpler?
Well, up until recently, the device manufacturers, their electrodes and their extension wires, and basically the little devices that you implant into the skull were pretty difficult to use. Sometimes they would sort of fall apart, and were just really easy to damage. Fortunately, a lot of improvements have been made recently, and now we have we get to choose from 3 different systems, which are all very well made and very easy to use, and more durable. So that's really good. So I think that technically the procedure has become a lot easier. I think for me, the most challenging thing is I'm a really strong proponent of performing awake surgeries. And prior to me starting as faculty at UCI, we never did any awake deep brain stimulation surgeries. They were all under general anesthesia. And it's really difficult to, when the staff is not used to that, to having to, make sure that the patient's not too sedated and talking to them, but also making sure that the procedure is done correctly. And there's just so many parts to this procedure. It's really a team effort. It's not a one-man show. And so you just have to have well-trained helpers that can assist with the surgery.
That makes sense. Well, thank you so much for your time this morning.
Yeah, thank you.
We really appreciated this, Dr. Paff.
All right,
I'll stop
thanks
the
so
recording.
much.